Good evening, everyone. Allow me to welcome you all to the Africa Healthcare Network Fireside Chat Series 113. My name is Dr. Omar Swali, and I am a consultant nephrologist working with the Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. It is my pleasure to introduce Prof. Michel Jadoul this evening. Prof. Jadoul is the co-chair of the Kidney Disease Improving Global Outcomes, the KDIGO, and also the head of nephrology at the Cliniques Universitaires, St. Luc, and also the professor of medicine at the Université Catholique de Louvain in Belgium. His clinical activities include the follow-up of hemodialysis and CKD patients, and his main research interests have included beta-2 microglobulin amyloidosis, hepatitis C, and other complications in hemodialysis patients, and as well as cardiovascular complications after kidney transplantation and various causes of kidney disease, especially drug-related. He has co-authored over 220 scientific papers, most of them published in high-impact nephrology journals, and he's also the theme editor for the Nephrology Dialysis Transplantation peer-reviewed journal. He is the country co-investigator for the Dialysis Outcomes Practice Pattern Study, the DOP study in Belgium since 2001, and he has also received an International Distinguished Medal of the National Kidney Foundation in the United States in 2008. He has been a member of the Council of the European Renal Association and the European Dialysis and Transplant Association, and is the editor-in-chief of the NDT-Educational since 2013. He is currently co-chairing the update of the KDIGO Hepatitis C virus and in CKD guideline, and he has also previously had one excellent talk with us on the 10 lessons to remember when treating glomerulonephritis, and he will be talking to us on something that is very pertinent in our practice, and that is the volume control in hemodialysis this evening. We would also like to thank the KDIGO for their support in facilitating these high-quality webinars. And with that, Prof. Jadoul, I welcome you for your talk. Thank you so much.
Thank you very much for the introduction and for the invitation. Now, I like to explain what I've learned over the years, and I like very much discussing with colleagues. And I like quite a bit traveling around the world, among others in Africa. You may know, maybe I mentioned that privately to some of you, that I have a daughter who has been walking from village to village across West Africa some years ago, 3,500 kilometers. So we went with the family. I've already traveled to a number of African countries. Now, anyway, my topic today is volume control in hemodialysis, and here are my disclosures. The main one, as mentioned on the slide and as already mentioned by the chairman today, being that I have the privilege since some years to be one of the co-chairs of KDIGO, the Global Guidelines in Nephrology. Now, KDIGO organized 4 years ago controversies conference about blood pressure and volume management in dialysis, so almost exactly the topic of my talk today. And so the paper derived from that meeting. Usually the controversies conferences lead to a paper published in Kidney International. And the aim of such a controversies conference is to delineate what we know and what we don't know. So in many topics, unfortunately, in nephrology, even though there is recent evidence in many fields of nephrology, so that's good news for the field, but there is not enough high-level evidence for a guideline. Still, it's useful to discuss the pros and contras, what we know and don't know. And the paper was published, the meeting was held in Portugal, in Lisbon. In 2019, the paper was published a year later and is not so old. So I will use that paper as the backbone. I've added a few more recent major papers that are relevant for this presentation. Now, as we all know, there is a tension in balancing the volume status. In the middle, you have euvolemia, when everything is or seems to be fine, and there are no specific short-term or long-term risks. On the left-hand side, you have hypovolemia, and on the right-hand side, hypervolemia. In both cases, when you are not, or your patient is not in the middle, there is an increased risk of death. And there may be complications such as hypotension during dialysis, vascular access thrombosis, muscle cramps, fatigue, with the risk, if there is hypotension, of end organ ischemia and a faster loss of residual kidney function. On the other hand, on the right-hand side, if there is hypervolemia, there will be more hypertension, edema, dyspnea, fatigue, as on the other side, cardiac remodeling, and an increased risk of eventually heart failure. Now, I cannot resist already make a personal comment, and whenever you see something in red, it's a personal comment of Michel Jadoul. Now, it happens that I'm a co-chair of KDIGO, but that was not specifically mentioned in the controversies conference report, which is always a compromise, 4,400 words. I want to mention already now that if you have fatigue and there is no overt hypervolemia, in my practice, I've learned personally that if there are no cramps or hypotension, you may think there is no hypovolemia. Still, I've seen frequently patients complaining from isolated fatigue. And one of the main questions I ask to a hemodialysis patients whenever they are speaking about fatigue is as follows: is the fatigue better if they are on the Monday, Wednesday, Friday schedule and are dialyzed 3 times a week? Thus, is the fatigue better on the Sunday? If the answer to that question is yes, well, I personally seriously consider increasing the target weight, because it may mean that there is fatigue related to infraclinical hypovolemia. And if that is true, then you understand easily that if body weight increases progressively from Friday to Saturday and Sunday, the fatigue improves, and that may call for a revision of the target weight. Here is the outline of my talk. We will briefly discuss 5 topics: blood pressure measurement and targets, pharmacologic approaches to blood pressure and volume abnormalities, the dialysis prescriptions as it relates to blood pressure and volume, extracellular volume management technology-based consideration, and finally, volume-related patient symptoms and experiences. Let's start with the blood pressure measurement and targets. 4 different topics: how and when should blood pressure be measured in patients on dialysis? What is the threshold for the diagnosis of hypertension in dialysis patient? What is the optimal definition of intradialytic hypotension on the one hand and hypertension on the other hand? Now, what is the gold standard? Well, all experts, but that is of course very hard to use routinely in clinical practice, but all experts would agree that the 24-hour, or in hemodialysis, ideally the 44 hours between 2 dialysis sessions, ambulatory blood pressure monitoring is the best way to have a good feeling of the average blood pressure. Still, it's not widely available, it's costly, it has a number of implications and barriers. Now, still, there was a meta-analysis published in CJs in 2006 showing that the pre- and post-dialysis blood pressure measurements in the dialysis units are very imprecise estimates of the blood pressure during the interdialytic interval. And the pre-session systolic blood pressure overestimates, so is higher than the average ambulatory blood pressure by something like 15 millimeters mercury, as you can see on this slide, and that is a rather consistent finding across studies. One reason for that overestimation may be the way the blood pressure is measured everywhere. This is a European study, but I guess that may be true elsewhere in the world, in the Americas, in Africa, in Asia, elsewhere. How is blood pressure measured in dialysis centers? Well, you can see that the back is frequently supported NDR, which are prerequisite for an accurate measurement of blood pressure. But if you are thinking about 5 minutes rest before measuring, that's less frequently observed, 80% only. If you think about the room is calm, it's only 70%. And we all know that in dialysis units, the room may not be calm at the time the blood pressure will be measured, and so on. There are a number of items for which the performance, and this is just a survey asking nephrologists how is the blood pressure measured in their units. Actually, it may even be worse than what the survey shows. So ambulatory blood pressure monitoring is the gold standard. Why is it the gold standard? Well, because it's the best parameter linked to the outcomes. If you link the outcomes and the outcomes like all-cause and cardiovascular mortality, you can see on this slide from the American Journal of Hypertension 2017 that by quartile, from quartile 1 to quartile 4, higher versus lower ambulatory blood pressure monitoring, there is a dose-dependent relationship with the outcome of all-cause mortality. If you look at the pre-hemodialysis routine measurement in the dialysis unit, there is no correlation at all. As you can see, the p-value is just almost 1, no correlation at all, whereas on the right-hand side, it's clearly significant. Alternative to ambulatory blood pressure is the home measurement, self-measurement by the patient. The p-value is just significant. Now, as you can see, the post-hemodialysis routine measurement performed usually by a nurse or a technician in the dialysis unit, the p-value is still not significant, but it tends to be better. You can see emerging a trend, but it's not significant. And if you have 24 or 44 hours ambulatory blood pressure monitoring, of course, you will be able to compare the pre-dialysis and the 48-hour, and you will see that in some percent, 9.1%, both will give you the same message. But in quite a number, there will be poor control with both, but in some others, there may be either good control with ambulatory blood pressure and poor control in the unit, or vice versa. And if you continue, you can think about white coat hypertension, masked hypertension, abnormal nocturnal dippic patterns. All of these are associated with adverse outcomes and may not be detected if you don't have a BPM. That being said, I agree that patients usually don't like it. It's not widely available and it has a cost. Ideally, if you perform it, you should perform it 44 hours between 2 hemodialysis sessions. The alternative, as I mentioned, is home blood pressure measurements. Either the patient will have a device or you can lend him for a few days and he may measure blood pressure twice a day. Of course, he should be educated about how best to measure the blood pressure at home. And in that respect, there is in the recent KDIGO, CKD and blood pressure guideline from 2021, if I'm right, there is a nice slide showing how to perform and what are the key points to perform accurately home self-blood pressure measurements. Still, it is true that ambulatory blood pressure and home blood pressure are the gold standards, if I may say so, but peridialytic before, during, and after are still necessary, just for one simple reason, for assessing the hemodynamic stability during hemodialysis, but not to make the diagnosis of hypertension. Now, what is the definition exactly of hypertension? When, of course, there is no high-level evidence in the dialysis world about what is optimal and what is accurate. So I would say you need an individualized approach that is necessary for all dialysis patients. And it is reasonable to use a target of 130/80, of 130/140 for those older than 65, and less than 130 for those younger than 65. But that is based on extrapolation from general population targets in the absence of high-level evidence from randomized controlled trials in hemodialysis patients. Let's move to the next topic, which is pharmacologic approaches to blood pressure and volume abnormalities. Well, when should antihypertensive medication be used? Well, for blood pressure lowering, the conclusion of the KDIGO controversies conference was to say that you should first consider non-pharmacological treatments. Sodium restriction, volume management, you could say ultrafiltration. If the blood pressure is still not at the goal, then you may add or titrate blood pressure medications. And if blood pressure medications are interfering with volume management, it is reasonable to consider reducing those medications to allow more volume removal. Now, for cardioprotection, it's of course very reasonable to initiate or continue blood pressure medication if given for a cardiovascular indication like coronary heart disease or heart failure, for instance. But the consensus of the conference is that we should not reduce ultrafiltration to allow an increase in blood pressure medications. So to make a long story short, optimizing volume status takes priority over the dosage of medications. Now, which ones as medications? Well, there is, of course, very little high-level evidence in hemodialysis patients, few randomized controlled trials. So the consensus was on antihypertensive medication, considered as first line in the general population, such as beta blockers, ACE inhibitors, ARB, calcium channel blockers, can be used as first line to lower blood pressure in patients receiving dialysis. And it is reasonable to choose a medication based on the patient characteristics and the cardiovascular indications. As a few examples on the next slide, carvedilol in those with FREF, a beta blocker for rate control or prevention of relapse of atrial fibrillation, or if they have residual kidney function, an ACE inhibitor and ARB may better protect the residual kidney function. This is not well demonstrated in hemodialysis patients, but at least it is logical to think that if there is propensity for intradialytic hypo or hypertension, well, whether the drug are eliminated by dialysis may be relevant. If there is orthostatic hypotension, you should avoid alpha blockers, hydralazine and minoxidil. If there is a high pill burden and the situation is relatively stable, you may consider a long-acting once-daily dosing. Now, what is the removal of frequently used antihypertensive drugs by hemodialysis? Well, ACE inhibitors, there may be some removal, at least for some of the drugs, such as enalapril and lisinopril, whereas there is very little removal for a few other ones, like shown on the slide. Beta blockers, it's highly variable from high removal to no removal, or zero for carvedilol. Angiotensin receptor blockers, typically no removal by dialysis. Calcium channel block, typically low to no removal. And that's something to keep in mind when you are thinking about dialysis hypotension or hypertension. And we move to that topic precisely. So there are no randomized controlled trials regarding the choice of one or another drug, whether it is or not eliminated by dialysis, and the impact of that choice on outcomes in hemodialysis patients. Still, the consensus was that it is reasonable to consider intradialytic blood pressure patterns with regard to the choice of blood pressure medications, and to use dialysable medication if there is intradialytic hypotension, and on the contrary, to use non-dialysable medication such as carvedilol or an angiotensin receptor blocker if there is intradialytic hypertension. Let's move to the next topic, which is the dialysis prescription as it relates to blood pressure and volume. Now, prevention, there are three topics in that section: prevention and management of intradialytic hypotension and hypertension, ultrafiltration rate, treatment time and residual kidney function, and dialysate composition and prescription. Now, intradialytic hypertension, the suggested definition from the conference was that any systolic blood pressure rise, usually there will be a decrease during the session, variable from patient to patient, but a rise by more than 10 millimeters mercury from pre to post-dialysis in the hypertensive range in at least 4 out of 6 consecutive dialysis treatments should trigger a potential diagnosis of intradialytic hypertension and prompt a more extensive evaluation of blood pressure and volume management. The estimated prevalence of intradialytic hypertension is something, depending on the study, between 5 and 15%. Definition may vary from study to study. At least what is clear is that there is intradialytic hypertension, that subgroup with an increase of more than 10 millimeters mercury has a definite worse outcome in terms of hospitalization, of mortality. So that's a high risk group in whom you should do whatever you can to improve the blood pressure control and hopefully the clinical outcomes. The second question is the intradialytic hypotension. Well, the suggested definition was in any symptomatic decrease in systolic blood pressure with symptoms, or a nadir intradiabetic systolic blood pressure below 90 millimeters, that should prompt again a reassessment of blood pressure and volume management. Now, it's much more frequent than hypertension. Prevalence ranges, depending on the study, from 15 to 50% of hemodialysis patients or sessions. It's definitely a serious complication. It's associated with vascular access thrombosis, inadequate dialysis dose, and mortality. And it's a function, blood pressure during the session is of course a function of a number of variables. Of course, the intravascular volume, so the key point of today, initial volume status, refill, what is the oncotic pressure, what is the hydrostatic pressure, how is the autonomic function. Then what about the available volume, the heart function, the vascular function, and lastly, blood pressure and volume are often not aligned. So it's a complex story, but if you have a stress with ultrafiltration and at the same time during hemodialysis vasodilation, there will be a decline in intravascular volume for two reasons, ultrafiltration and vasodilation, and there may be intradialytic hypotension, decreased organ perfusion, and end organ damage. On the other side, if there is volume overload, that may cause as well quite clearly end organ damage and clinical complications. So the target weight is the most basic key parameter of any hemodialysis session. It's a critical element of the prescription. Now, a target weight that is too low frequently leads to hypertension, and a weight that is too high results in volume overload. Everybody listening to my talk knows that, of course. Now, the result is that, as I mentioned from the onset, that there is a narrow therapeutic window. It's even more complex because healthy people have a very stable body weight. Now, I'm fortunate, even though I'm 64, to be healthy as yet. Now, my weight didn't change during 3 decades by more than 1 kilogram. But we all know that hemodialysis patients are not healthy. So their target weight or their weight will vary dramatically over the weeks, months, years, and they may change dramatically. So patients may gain or lose what I call dry weight, or if you prefer, lean body mass or fatty body mass. And I want to show a few slides. I usually don't use the slides, but I explain exactly the same. I'm confident that everybody in the audience knows that, but I think it's an excellent way at least to explain to patients what we are speaking about in hemodialysis. Now, if you are making a fire with a piece of wood or a fire with organic material, like here at the top, cereals, bread, or carbohydrates from fruits, okay? You will burn those carbohydrates. If you burn, as shown here at the bottom left, meat or cheese or fish or eggs or whatever people are eating, you will be burning hydrocarbons. And these will be combined during the combustion reaction with oxygen. And that combustion reaction will produce carbon dioxide, water, and of course, energy. And the energy will be ATP for the living cells of a human being or any other human or any other living species. So you will produce water. Now that is frequently overlooked. So that means that the weight can be stable in hemodialysis patients, and it will be stable if the target weight is not adapted based on your prescription, despite substantial ongoing loss of body mass. Muscle fat are burned, as I mentioned in the previous slide, are based on hydrocarbon and are burned and are transformed by the Krebs cycle. We all have learned that at medical school. There will be production by the Krebs cycle of ATP, of CO2 and water. So there is production of water. The second key point is that there is no reason to let patients have in their body, as I say to them, a luggage of water. And remember, a luggage of water is only visible if it is 3 to 4 kilograms or liters, if you prefer. Lastly, any intercurrent illness, such as major surgery, inflammation, typically associated with infection, pneumonia, whatever, hospitalization, frequently will cause catabolism of hydrocarbon organic material. It may be fat, it may be proteins, it may be carbohydrates, so it will produce water. Thus, what I've done in my clinical practice for decades now is that I've started reducing the target weight very early after the start of such an illness. I prefer that to being the late fireman when the whole body is full of water. Of course, this requires education of patients and staff to explain why the target weight. I've heard hundreds of times patients telling to me, "Oh, doctor, I'm already so thin and you still reduce my weight." Of course, I can understand that comment, but at the same time, that comment means that they do not understand what happens when there is intercurrent illness and that hydrocarbons are converted to CO2 and water, and the water needs to be eliminated. And the only way to increase the target weight is to stop the intercurrent illness, the inflammation, to be able to let them eat better. And as such an example is after chronic hemodialysis start. I've seen that again hundreds or thousands of times. I'm sure you have seen the same. Especially if hemodialysis has been started very late, there is a recovery phase during which especially younger people will recover relatively rapidly. And there will be the opposite of the catabolism. When there is intercurrent illness and inflammation, there will be anabolism. So when the hypervolemia that may be present at the start of hemodialysis is corrected, appetite will increase, and you should expect an increase in the target weight. There is a typo, sorry for that. Now, what about ultrafiltration rate? Well, higher ultrafiltration rate, even as low as 6 milliliters per hour per kilogram, which is not that much, are associated with higher mortality risk in multiple studies. And of course, this is highly plausible that higher ultrafiltration rates may cause end-organ ischemia at the heart, the brain, the liver, the gut, the kidneys. A critical unanswered question is how to balance the potential risk from higher UF rates with the potential risk from volume overload. If you want to reduce the ultrafiltration rate, well, the simple answer is that you would increase the dialysis time and or decrease the weight gain. Now, speaking to patients about what they are drinking, I will discuss that later during my talk, but telling a patient on hemodialysis that he should drink less to reduce interdialytic weight gain does not make any sense if you don't say at the same time that he should eat less salt. We all have in the hypothalamus, in the brain, a thirst center, and the natremia is managed exactly in the same way in a hemodialysis patient, or very similarly as in you and me. So if patients on hemodialysis eat a lot of salt, they will be unable not to drink because their natremia will go up. So what you can do in order to try to reduce the ultrafiltration rate is, of course, increase dialysis time, but that has a cost, barriers, and so on, and decrease the weight gain. Decrease the weight gain means, number one, less salt intake, dietitian explaining what foods are rich in salt. We can discuss dialysis sodium in a few seconds. And then diuretics, if there is residual kidney function, I've put that in red, but in those with high interdialytic weight gain, you may consider two things. Number one, high dosage of loop diuretics. Now, of course, if they urinate 100 milliliters, it won't change a lot. But if they still have 300, 400, 500, and you give them a lot of furosemide or bumetanide, which is inexpensive, it may help because they may urinate 300-400 milliliters more. The second point that has helped me in my practice is that in those with high interdialytic weight gain, if they complain of thirst after the hemodialysis session, you may consider adapting the dialysate sodium to reduce the ultrafiltration rate and adapting the dialysate sodium to the pre-dialysis plasma sodium in that patient. And that is based on a small randomized control trial published by a Brazilian group some 20 years ago, 19 years ago to be precise, initially in that dialysis unit in Brazil. And that paper was published in KI. I saw that at the ASN some years ago already. The initial standard dialysate sodium in the unit was 138. And the authors had the idea to think some patients complain of having thirst at the end of hemodialysis session. We will, in those who start hemodialysis with a sodium around 134, we will not use 138, but something like 134, 133. As you can see, the post-hemodialysis, instead of going up, as you would expect, if it is 138, went a little down, but did not increase. And as a result, during the course of that small-sized and short-term study, the interdialytic weight gain went down from 2.9 kilograms to 2.3, a highly significant difference. And the ultrafiltration rate could also be reduced. So that's one way that has helped me, not in every patient, but if they start the dialysis with a relatively low pre-dialysis sodium, probably because they have a thirst center that their set point for the normal natremia is something like 132, 133, it does not make any sense to use 140 in the dialysate sodium. And usually in a patient that's very stable over the months or years. So if you measure that a few times in a year, that's probably enough. What about ultrafiltration rate tolerance? Well, there is the whole discussion of cool dialysate. I will come back to that later. Higher dialysate sodium, as I mentioned, very little evidence. Higher dialysate calcium, little evidence as well. Ultrafiltration profiling, again, limited evidence. Isolated ultrafiltration followed by hemodialysis. I've used that like many of you probably, but the evidence level is relatively low. Hemodiafiltration is certainly one possibility, probably because the temperature of the patient goes a little down, but it has a cost as is not widely available. And of course, improving the overall health, but that's what we all want to do for our patient, but it's complex. So a lower dialysate sodium is associated with a lower interdialytic weight gain and blood pressure, but in some studies there may be more intradialytic hypertension and symptoms, including cramps, even though if the patient has a lower initially plasma dialysate sodium, it may be well tolerated. There was a randomized control trials that was not discussed at the KDIGO meeting by Mark Marshall from Australia, effect of low sodium versus conventional sodium dialysate on left ventricular mass in home and cell case satellite facility hemodialysis patient. Was an RCT, as I mentioned, essentially a negative study, 135 versus 140. As you can see, no improvement of left ventricular mass or hypertrophy, if you prefer. So a bit disappointing. So there are a number of patient factors: poor ultrafiltration tolerance and higher interdialytic weight gain, autonomic dysfunction, heart failure, vascular stiffness, and atherosclerosis. There are a number of interventions. We have already discussed a few of them. The frequency and duration, that's of course ideal because our kidneys are working 7 days a week, but it's hard to do practically. Cool dialysate, I'll come back to that in a few seconds. We discussed sodium load, avoid very low calcium, that's logical, but that does not mean that the high dialysate calcium helps a lot, and there may be other consequences in terms of vascular calcification. It's quite logical to reduce the dietary sodium. In some patients, the dialysate sodium and to enhance the volume output by diuretics. And of course, if the weather is hot, well, it may help with loss of sodium through the skin, but that usually will not produce a major loss of sodium. Residual kidney function, is there any way to have an impact on that? Well, high flux membranes, now relatively widely used, to the best of my knowledge, have some benefit. On the other hand, whether you improve the residual kidney function with ACE inhibitors or ARB, just a little evidence, but not much. And avoiding intradialytic hypotension is probably helpful, but again, that is also not well demonstrated. So unfortunately, very little evidence. What are the best tools to assess volume in a hemodialysis patient? Well, as you can see on this slide, there is at least a dozen of items. And as you can easily understand from the listing, if there is a dozen, it means that none of them is perfect and none of them is fully reliable. The history of and symptoms remains key, in my opinion, and physical examination in some patients. Blood pressure measurement may help, but you should remember that the blood pressure measured in the dialysis unit is very imperfect. Then there are a number of other investigators, like inferior vena cava diameter, lung water ultrasound. I will briefly discuss that, bioimpedance, relative blood volume monitoring, biochemical markers, extracellular volume, even more costly and not available at all, chest X-ray, low accuracy, of course, low risk echocardiogram. So none of these is perfect. And my good friend Carmine Zoccali, a past president of ERA, decided to perform a randomized multicenter trial published a few years ago in Kidney International of lung ultrasound guided treatment strategy in patients on maintenance dialysis with a high cardiovascular risk. Now, if you use a point of care ultrasound, you put the probe on the skin and you have an ultrasound beam that will go from the skin to the pleural line and the subpleural space. Now, if the patient is normovolemic, you just have one A line, like shown here. But if there is hypervolemia, now, it is important to mention that those B lines shown here, the multiple lines shown here at the bottom on the right-hand side, they are not specific. So in someone having pulmonary fibrosis, you have exactly the same. But of course, if you reduce the target weight in someone with pulmonary fibrosis, the B line will not go away. Whereas if it is infraclinical lung edema, which is the case in most hemodialysis patients, well, it is reversible with an adaptation of the target weight. That is the principle. So they randomized more than 360 patients to two groups: the usual care, no lung ultrasound, and the other group, lung ultrasound, in addition to the usual care. Some of them withdrew from the study in both groups, and 152 and 55 in both groups completed the study and were included based on an intention to treat in the primary analysis. They were aged 70 years with a dialysis vintage of 5 years, 40% diabetics, 40% with a history of heart failure, and 25% with a history of atrial fibrillation. Now, if you use the lung ultrasound over time, you will be able to reduce the subclinical lung edema. As you can see, as compared with the usual care, the number of B lines will at least go down, or at least it will increase in the usual care group. And the difference between both groups is significant. That being said, the good news is that there are no more adverse events. There is even slightly less hypotension, but significantly so, 3.2 versus 4.7 in the usual care arm. So there is no harm in that respect, but there is no difference in terms of arrhythmia or vascular access problems. So it seems to be safe. On the other hand, there is no difference on the primary endpoint of the STE or the composite of death, MI, or de novo decompensated heart failure, or all-cause mortality. There is a small difference, but very far from being significant. It is true that on some secondary outcomes like recurrent decompensated heart failure episodes, the lung ultrasound group does better than the usual care group. It's significant, not a dramatic difference, but a significant one. And the total recurrent cardiovascular events, again, there is a significant difference, but that's a secondary outcome of that trial. What about other technical intradialytic strategies for managing the blood pressure and the volume? I will discuss the MyTemp trial and the impact of the temperature of the dialysate on the hemodynamic stability. About the blood volume monitoring, the consensus was that there was conflicting evidence whether relative blood volume monitoring, whatever you call it, be it blood BVM, the Fresenius machines, or the Baxter ones, it would be Hemoscan or whatever the company that produces your dialysis machines. This is relatively widely available. Still, there was unfortunately a single trial in the United States in which the Guideline device was used to monitor during the dialysis session the blood volume. And unfortunately, as I would say, I still do not understand that. I've read carefully that study. I suspect it was poorly performed. It is the US setting, but there was a greater mortality and hospitalization rate in the subgroup having the Guideline versus nothing. So that has been a disincentive for the use of that technology. My opinion is that I still believe that blood volume monitoring during the session has helped me to adapt the target weight, taking especially into account the trends of blood volume monitoring over time. If the blood volume monitoring tells you that usually that patient by the end of the session is at 93% of the start of the session, and 1 week or 2 weeks later it's 85%, that tells you something. It may mean that the target weight will soon need to be readapted. Now, a few words about the dialysate temperature. There has been last year at ASN the presentation by Amit Garg from Ontario of the personalized cooler dialysate for patients receiving maintenance dialysis. So the MyTemp, it's a pragmatic cluster randomized trial. Now they enrolled in most of the centers in Ontario, 84 out of 97, and the centers, not the patient, the centers were assigned to personalized cooler dialysate, 8,000, or standard temperature dialysate, 7,400. Now quite a number, of course, withdrew because of a kidney transplant, transfer to home dialysis, or a number of other reasons, whatever. Still, there were so 42 centers in both groups, typical in-center hemodialysis patients with an age of 65, with, if I recall correctly, 40% diabetics. No, sorry, 60% diabetics with a number of comorbidities, and you have here a long listing. I will not detail that for the sake of time. So typical patients of an in-center hemodialysis unit in Canada. Now, the strategy was successful in terms of dialysate temperature. As you can see here, the dialysate temperature in the standard care group was 36.4, but not 37. That is something that deserves a comment. I will come back to that later. And in the low temperature group, it was 35.8. So the difference between both groups was maintained over time, as you can see, and was 0.6 degrees Celsius, highly significant. Still, the trial was definitely negative, as you can see on the primary outcome of cardiovascular mortality. There was no difference at all, as you can see on the slide, both curves being almost identical, the p-value being 0.93. And this is true for the secondary outcomes of hospital admission with MI, 0.93, ischemic stroke, 106, congestive heart failure, 0.96, 103, 103, and so on. You can see here the outcomes, but none of these is significant. And even for intradialytic systolic blood pressure, there was no difference between the standard temperature and the personalized cooler dialysate, which was lower. You will remember that by 0.6 degrees Celsius. So the editorialists, Nick Selby and Maarten Dahl in the Lancet, say that the magnitude of cooling in the intervention group, they are not sure that the magnitude of the cooling was sufficient, bearing in mind the real world scenario. There were 20% non-compliance with treatment in both groups. There was some overlap between groups because some in the intervention group were dialyzed at 36.5, and the mean dialysate temperature in the control group was 36.4, whereas most previous studies showed a benefit when the control dialysate temperature was 37. So the editorialists conclude that the trial should not be interpreted, even though it's a high quality one, as definitive evidence that cooling the dialysate is ineffective for individual patients, and that further research could focus on the responses of specific subgroups to dialysate cooling and clarification of whether there is an optimal level of dialysate cooling with respect to change in body temperature. My 5-cent comment about that would be that anyway, nowadays we always should avoid using 37 degrees Celsius temperature of the dialysate, even though it is unclear as yet whether 35.8 is better than 36.4, but the standard temperature in my unit is 36, and so whether 36 would be better than anything remains to be demonstrated, but still our feeling is that it is well tolerated and probably helps a little bit. What are the possibilities? I will come back rapidly to ultrafiltration profiling. As I mentioned, isolated ultrafiltration, limited supporting evidence. Sodium profiling, to be honest, no evidence, even some observational data from the docs suggesting that it may be detrimental. I don't use it. Now, to turn back to ultrafiltration profiling, so the idea is that at the onset of the session, the ultrafiltration rate is higher, and you reduce it during the duration of the session. And Jenny Flight from North Carolina in the US performed a small-sized randomized crossover trial. You have here the design of that study, showing conventional ultrafiltrate and a washout period of a week, then ultrafiltration profiling, again washout, conventional washout, UF profiling, and vice versa, crossover over a duration of a total of 14 or 16 weeks. A small number of patients, and I can't move the slide now, so, okay. A small number of patients, a total of 34, but as each patient is his own control, it's still a good design of a trial. And unfortunately, again, no difference for any of the items, neither for intradiabetic hypotension, troponin T rise, left ventricular mass change, plasma refill, target weight achievement, cramping, nausea, etc. No difference at all. So honestly, ultrafiltration profiling, very little evidence. Bioimpedance, there may be a role for that in extracellular volume management. I don't use it routinely in my unit. Hemodiafiltration, as I mentioned, not routinely available. Before concluding, a few words about volume-related patient symptoms and experiences and non-pharmacologic interventions. Well, as I mentioned from the onset, salt and fluid restrictions are the cornerstone non-pharmacologic strategy for blood pressure and volume management. However, data supporting their effectiveness is relatively limited. Some evidence for psychological intervention for addressing non-adherence to fluid restriction, and small studies have shown that restricting small salt intake can reduce interdialytic weight gain in patients receiving under hemodialysis and blood pressure in patients receiving PD. And my good friend Charlie Thompson, formerly a nephrologist from the UK, now emeritus, published some 20 years ago a paper in NDT saying what I just mentioned some minutes ago, advising dialysis patients to restrict fluid intake without restricting sodium intake is not based on evidence and is a waste of time. He even said in the paper that it may be considered as violent because it's useless. You will ask them to do something that is impossible if they do not restrict sodium intake, because their natremia will tell to their brain that they should drink more water. Lastly, we all know that dietary and fluid restrictions are burdensome to patients, that eating and drinking is part of normal life. So we should try whenever possible to promote salt literacy, to motivate patients, but that will not be the ultimate solution, as we all can imagine. So in conclusion, I do not have any magic solution for that key, highly relevant topic, but managing blood pressure and volume in dialysis requires an individualized approach with integration of numerous clinical dialysis treatment and patient factors. There may be some technologies and clinical protocols that offer promise for advances in blood pressure and volume management, but there is a clear need for the design and implementation of additional high-quality studies in this critical yet understudied area. And at the end of the KDIGO controversies conference, there were in the paper a number of research recommendations. As you can see here, there is a full table with a long listing of things that are unknown, on which there should be additional research. And of course, nowadays you could speak, I did not want to do that because that's not yet widely available, about biofeedback on the dialysis machine or artificial intelligence, whatever. There are now recent papers about that, but that will be still years before that becomes available to you and even me. And with this, I thank you for your attention. And I'll be happy at least to try to answer the questions you may have. Thank you.
Thank you very much, Prof. Jadoul. This was an exciting presentation and especially pertinent again for those of us facing dialysis patients on a day-to-day. I'd like to take this opportunity to welcome questions in the Q&A chat box or in the regular chat box, and also by raising your hands, and we will unmute you and allow you to speak if you have any questions for Prof. Jadoul. While we await questions, we will be having a recording of this beautiful presentation on YouTube, hopefully by Monday evening. We would like you to subscribe to the channel Africa Healthcare Network Fireside Chats to have access to this talk and the ones we have had previously. We have some senior members on the panel. We have Dr. Ahmed Tahir from Kenya. He's a senior consultant nephrologist. We have Dr. Gagio Tseve from Botswana. We have Dr. Egina Makwabe, who's a senior nephrologist here in Tanzania. And I would actually invite Dr. Tahir to ask the first question.
Yeah, I see your hand. Yeah,
Dr. Tahir, please, welcome.
Thank you, Professor Jadoul, for a very exciting lecture. My question is, in order to reduce intradialytic hypotension, is it not more logical to reduce the UF rate in the beginning and then increase it as if the patient tolerates? Or is it better to set a high UF in the beginning and reduce it towards the end? That's my question.
Okay. A very good question, a very practical one. So I would answer the following. I've seen I'm sure everybody on this session has seen that repeatedly during his career. I've seen thousands of hemodialysis patients. There is a subset, I still don't know why, even though they apparently don't have any allergy to anything and they have a good or reasonably good heart function. There is a subset, I don't know why, who have at the onset of the hemodialysis session relatively rapidly a blood pressure drop within the first few minutes. So in those ones, I would fully agree with you. In the other ones, I would suggest that usually the most logical is to do the opposite, but still the ultrafiltration profiling, meaning more ultrafiltration initially and then less over the course of the session, because at least pathophysiologically, the more there is too much fluid, and you would expect that that would be the case at the beginning of the session rather than at the end, the more there is excess fluid, the easier it will be for the blood pressure to ultrafiltrate without blood pressure drop. But that's a reasoning. and we are all dealing with individual patients. So with the exception of the few patients in whom there is clearly repeatedly at each session a blood pressure drop at 2, 3, 5, 10 minutes, in those ones I would start with, for instance, no ultrafiltration, and after 10, 15 minutes start increasing the ultrafiltration. But with that exception, I would say that I would within minutes start the highest ultrafiltration rate and probably decrease over time. But there is no evidence that having it higher versus low or continuous across the 4 hours, if it is 4 hours, makes a difference, as I mentioned.
Thank you very much, Prof.
Thank you very much, Prof. Jadoul. And from the Q&A chat box, we have Dr. Alfred Merebo, who is a senior nephrologist in Dodoma, Tanzania. And he's thanking you, first of all, for the wonderful presentation, but also he has this one patient who always comes in with a very high systolic blood pressure of more than 180. But when the dialysis is started, and just within the first hour, the systolic BP drops to less than 90. And despite assessing and addressing all the issues with regards to intradialytic hypertension, he's still facing his challenges. So what would your expert take be on this?
Several comments. Number one, I would like to say, as I mentioned, and I'm sure everybody was listening very with much attention to my talk, that's not the point, but number one, remember the pre-dialysis blood pressure, if it is 180, my first comment would be please let it measure again 5 minutes after the start of the dialysis session, just not to delay the start of the session, or even a few minutes later. Sometimes you will have 180, but because the patient has been rushing to come in, and 5 minutes later he's calm, he's quiet, and the blood pressure may be 150 or 140. So that tells you something that is important. And then if you, whatever the blood pressure, if you have intradialytic hypotension, we are back to that topic, I have no magic solution. You have the usual measures, usually performed by the nurse, the stopping ultrafiltration, Trendelenburg position, and then potentially injecting hypertonic saline and then reducing ultrafiltration. I mean, I have no, if it would be simple, we would not be speaking about that today. I have no magic solution.
Thank you very much, Prof. And then we have another question from Dr. Juliet Batanita, who is a fellow in nephrology in Tanzania. And for a patient with septicemia presenting with normal blood pressure, mild lower limb edema, and no pulmonary edema, during the first dialysis session, would you advise ultrafiltration?
Well, if the patient has overt septicemia, there is a balance to find between the short term and the middle term. I would say the short term is the current hemodialysis session. Now, we all know that if you have septicemia and potentially high fever, it may improve, of course, with antibiotics over the course of the days. But if you have septicemia, you may have vasodilation, and that's not the best moment to increase ultrafiltration. So it may, when I said if there is intercurrent illness, it may not be at the time of suspected or demonstrated septicemia that it is best to increase ultrafiltration. That's true. On the other hand, if there is septicemia, unless it improves very rapidly with antibiotics, I would expect that the target weight, there will be some calories, fat, or as I said, fat, lipids or proteins, muscle, whatever, that will be burned, and the target weight will decrease. So if it is not at this session, it may be the next one or a week later, but probably not in a month. Otherwise, the patient may come in. If he loses 2 or 3 kilograms of lean body mass, he may come in because he produces water. He may come in with acute lung edema.
Thank you very much, Prof. And again, another question in the Q&A chat box asking what sodium profiling is all about. The person asking would like clarification on that.
Well, sodium profiling is a little bit a strategy that is similar to ultrafiltration profiling. So the idea is to have high sodium in the dialysate at the beginning of the session and reduce it progressively over the course of the session, with the idea that there will be some sodium transfer to the patient at the beginning of the session, helping for greater ultrafiltration during the first part of the session, and you reduce that over time. There is no evidence, honestly, scientific evidence. The dialysis industry has made a number of those softwares available on many dialysis machines. I've tried it. I've stopped using it 20 years ago. I've never been convinced it's very helpful, but that's the concept. And I can understand the concept, but there is no demonstration that the concept has translated into clinical benefit. That would be my summary.
Thank you again. And Dr. Lloyd has a question. Dr. Lloyd, can you unmute yourself?
Yeah, it's on the chat box. Can you just read it or I can tell it?
Sure. So Dr. Lloyd has put on the chat box that what would be your best approach to fixing a target weight for a new patient on dialysis right from the start of the first dialysis?
Yeah, again, a very important question. And it's, as I say to my patient, it's not written the target weight on their face. So we have to deal with our stethoscope, our brain, and our hands. Firstly, looking clinically at the patient. As long as there is hypertension, edema, and breathing difficulties, well, it's easy. You reduce the target weight session by session in order to improve, let's say, the symptoms and signs of the patient. If that has resolved, I just want to repeat that infraclinical hypervolemia is frequent, and in CKD, and of course in dialysis patients as well, between hyper and hypovolemia, there is a gray zone of something like 3 to 4 kilograms. So it's not so easy. Patients may not yet be hypovolemic and may still be hypervolemic, even though they don't have edema. Now, if the blood pressure is perfectly normal, I would then try to think that the target weight becomes correct. The aim is, of course, on the one hand, to preserve in as much as possible, if there is still is residual kidney function, which may help the patient in real life, to reduce interdialytic weight gain. If the target weight is too low, that may be detrimental to residual kidney function. But on the other hand, as I said, having a luggage with 3 or 4 kilograms of water does not make any sense. So we have to find a way, if there is no hypotension and cramps, if there is fatigue and there are no more edema, breathing difficulties and hypertension, we may be a little bit on the low side. If there is no fatigue, no blood pressure drop during the session and no muscle cramps, my tendency when dialysis is started is to reduce until there are no overt signs of hypervolemia. I would not necessarily go to the last drop or the last milliliter for one simple reason, and the simple reason is that I know that if the patient recovers, I expect within a few weeks that the appetite will come back and the target weight will increase again. So eliminating the last drop means I will have to eliminate the last drop, but I will have to give it back within weeks because the target weight will have to increase if the general health status of the patient improves. So that would be my summary. But it's a gray answer, meaning again we have to do that on a day-to-day basis.
Thank you so much, Professor Jadoul. Thank you very much.
I see also another question, if I may, on the nurses sometimes drop the pump speed. Does this have any effect on intradialytic hypertension? Thank you for the question. I like it, like the previous ones, very much. Honestly, I have seen that in my career. I have been trained mostly in Belgium. I also trained a year in the Netherlands. I have seen it in my career thousands of times. What is the evidence for that? Zero, honestly, zero. Is there evidence that if you reduce the blood flow, which is the suggestion of the question, if you reduce the blood flow from, let's say, 360 to 300 or from 300 to 250, does that have an impact on intradialytic hypertension? There is no evidence, no scientific evidence. I don't think that helps. Still, I'm not fighting with the nurses if there is intradialytic hypertension and they want to reduce the pump for a few minutes, but I remind them that they should re-increase as soon as the blood pressure is better. But I don't think, honestly, it helps.
Thanks a lot, Prof. Jadoul, for that. It's just a practice that I've seen over the years. And as you said, there's no scientific evidence for it. I was looking hard for it. Yeah.
It's not just in your country, it's everywhere, I think.
Yeah. Okay. Well, thanks a lot.
It should be tested in a well-designed study, but it hasn't been, to the best of my knowledge.
I agree.
Thank you, Dr. Rima, and thank you, Prof. We also have a question from Dr. Ali Fatih Hassan, who's asking if ultrafiltration can help in the treatment of a dysnatremia.
Ultrafiltration can help in the treatment of what? Dysnatremia?
Dysnatremia, yes.
But dysnatremia, you mean too high sodium or too low, or both?
I'm assuming he means both in this case.
Yeah. Well, if you ultrafiltrate, I just want to remind you that an ultrafiltration means that you eliminate volume with exactly the same concentration of sodium as in the plasma of the relevant patient. So intuitively, I would not expect, unless one theoretical example, you would eliminate 5 liters of ultrafiltration and the natremia is too high, and the patient would drink 5 liters of water. That would, of course, intuitively help reduce the natremia, but intuitively I would think that this natremia, I would think that hemodialysis, not too fast, but hemodialysis is the best way to change the natremia level rather than ultrafiltration.
Thank you again, and I believe this should be one last question again from Professor Kajiru Kilonzo, who is a senior nephrologist in Moshi, Tanzania, and he's seeking your opinion of cramps and hypotension during dialysis. Does it relate to the high ultrafiltration and the poor intravascular refilling? Can't a fluid overloaded patient not get hypotension or cramps in this case?
So, number one, indeed, muscle cramps and hypotension, especially muscle cramps. I explain that to my patients. If you are looking at the soccer World Cup final and the weather has been hot, and if there is another 15 minutes to play and you can see that the players have muscle cramps, well, they had heavy loss of salted water through the skin. And it's exactly the same during the dialysis session, with one exception. The salt and water loss is through ultrafiltration or through the dialysis session. But the mechanism is hypoperfusion of muscles. Why? Well, because muscles are less important than the brain, the heart, and the other critical organs. So the muscles are the last ones. And so hypotension and cramps are frequent. Now, that does not mean that someone with a poor heart function will not have muscle cramps, even though he's still hypervolemic, because if the heart functions poorly, the refilling will be worse, and if the refilling is worse, then you may still have muscle cramps and hypotension, despite the fact that there is still too much fluid in the body. Then the only way to help, or try to help, is to have slower, longer ultrafiltration. I'm not sure that answered the question. If not, please repeat the question, but at least that would be my comment. Maybe I missed part of the question.
I believe, Prof, that you have addressed the query here. So thank you very much, Prof. Jadoul. Again, a lot of us have learned a lot of new things in this session, even though we face this on a daily basis. I'd like to thank you for taking your time out again to join us.
My pleasure.
And hopefully we will be asking you to come and give more talks to us in the future. And we really look forward to those as well.
Good evening to all.
Thank you very much, Prof. I would just announce that we have the Google Docs form for the CPD points for the Tanzanian attendees who are claiming the points for their medical council registration. And also, I would also like to thank the KDIGO again for partnering with the Africa Healthcare Network for this beautiful presentation by Prof. Jadoul tonight. I would like to hand over to Dr. Lloyd for a vote of thanks and a very good evening from my side.
Thank you very much, Professor Jadoul. Extremely grateful for this wonderful session. A very, very common problem and it's a great advice that we received today. So we would put this up on YouTube and it's available to everybody.
Okay.
By Monday, it should be up. Thank you very, very much for readily coming on to talk to us again in Africa. And we hope that you would come again. Thank you so much.
Thank you. Bye.